Aloha! This CME activity is jointly provided by the Queens Medical Center and UH-JABSOM Department of Geriatric Medicine. We offer free continuing education for this series. In order to receive a CME or CEU, participants must complete the online evaluation at the end of the webinar. Your comments are very important to the planning committee and will be used to plan future programs. You can now check on your CME credits online. Go to www.queens.org and type search tool. Click on My CME Transcript, then sign in to generate your transcript. If you have any questions about accessing your CME, please email cme@queens.org. About ECHO, we want to remind everyone that this is an ECHO webinar, which means that this session serves as a forum for mutual teaching and learning from experts and from each of us on the front lines. As the ECHO motto goes, all teach, all learn. So it will take all of you to create this community of learning. In the spirit of aloha, we encourage you to turn on your cameras to help us build a community of learning. Feel free to eat during this ECHO session. Good nutrition is key to a healthy lifestyle. A little bit about our format. A short lecture from our experts will share expertise from the rest of the team and then open the time up for case discussions. We invite you to share any geriatric cases. It may even be on a topic not related to the topic of today's lecture. We only ask that you keep it HIPAA compliant case for discussion. This means please do not share patient's name, birthday, address, and so on. We learn best from our patients. They are the best teachers. Our interdisciplinary team is here as well, and we are all willing to teach and share our collective wisdom with you. Most of you already know me. I'm Juanette Gaylord, President of Alliance of Residential Care Administrators, ARCA. We have Maribel Tan, President of Foster Family Homes Association, Elsa Talavera, President and CEO of All Island Case Management Corporation, Kira McCoy, Health Coordinator, Lead at Aloha Care, Leila Ventar, Health Coordination Manager from United Healthcare, Hawaii County, and Dr. Rita Bell Fernandez from University of Hawaii. We are in the second month of our third-part series on what matters. If you are interested in viewing any of those lectures and handouts, you can find them on our website. Unfortunately, we cannot offer certificates of attendance for videos you have viewed. You must participate in our education live. The title of today's webinar is Extra Support for Those with Serious Illness, Palliative Care. Now it gives me great pleasure to introduce our speaker, Jeanette Koljane, MPH. She is the Executive Director of Kokua Mau, a statewide network in Hawaii comprised of organizations and individuals dedicated to enhancing care. Kokua Mau was established in 1999, and she has been the Executive Director since 2010. Jeanette earned her MPH from the University of Hawaii and her BA from Cornell University. She has been involved in serious illness care since 1988, starting in the field of HIV/AIDS, being the Director of International Programs, where she worked on the AIDS Memorial Quilt. She has since held various research and educational roles in Berlin, Germany, and San Francisco. Jeanette actively works in the U.S. affiliated Pacific Islands to help develop palliative care programs. Welcome, Jeanette.
Well, thank you very much, and thank you so much for the invitation to talk with you today. I'm going to share my slides and hoping that you can see that. Okay. Are we doing okay? I just got a nice note that my internet is unstable, so I'll look to you guys in case I need to change something, okay? Great. So, again, thank you so much for the invitation, and I hope that you will think of Kokua Mau as a resource in our community. As Juanette mentioned, Kokua Mau is now going on 25 years in Hawaii, and I I think that we're a unique organization because in Hawaii, we're unique, that we all try to help each other. We all know each other. And I know certainly that's you guys do that as well. So I hope that you will see us as a resource for you. So we like to think that we are leading a movement that is going to make advanced care planning and communication about care and support for people with serious illness, their loved ones, and the people that care for them our cultural norm. So we are a nonprofit organization. We're not a state agency. We depend on membership from a variety of different organizations, including health plans, hospitals, hospices, all sorts of different community groups. And I get to work with some of the most amazing volunteers across the state, including people like Leslie Milligan, who is going to be part of the presentation. She's going to do a short case study later. So Kokua Mau, we try to start early having conversations about care. So advanced care planning, hopefully everyone's familiar with advanced directives, healthcare power of attorney. So you can find those documents in 13 languages on our website. POLST, that is also our kuleana. We work on POLST. The materials about POLST are on the website, and I'm actually the POLST coordinator for the state, or the POLST point person. Kokua Mau wants to explain to people, make people aware of how what palliative care is and what an amazing opportunity it is. And we'd like people to understand what hospice care is, how it's different from palliative care, but also very important care for people who are then coming to the end of their life. And then we also have resources on grief and bereavement. So as an icebreaker, I would love it if you could put into the chat the first thing that comes to mind when you hear the word palliative care. So I'd love you to put it in the chat. When you hear palliative care, no shame, just tell me what you think of. And yes, you have to write something down, right, doctor? Okay, we need good comfort, free from pain. That's a good start. Comfort care, but not curative. Wait for that. Support, help families, quality of life, no pain, listening to what wants and needs. Hey, you guys are good. Okay, this is a good start. So here are some other words that come up: respect, support, pain management, decision making, family, spiritual care. So I'm really glad that we can talk about palliative care this morning. And this morning, I just ate lunch. It's not morning, it's afternoon. So I think it's really important to say that out in our community, so somebody's not muted, if you would please mute yourself. There's a lot of misunderstanding about what palliative care is, so I'm glad we can talk today. And I think it also is important to say that different health plans, for instance, will have different interpretations of palliative care, different benefits are available. So if you're a little bit confused about what palliative care is, that is not surprising. So palliative care, as an official version, is specialized medical care that focuses on providing patients with relief from symptoms and stress of a serious illness. The goal is to improve quality of life for both the patient and the family and the loved ones. And palliative care is provided by a team. So the team is usually a doctor, nurse, usually a social worker, somebody to think about spiritual issues, but there's other specialists that will come in and then partner with the patient's other doctors to give this extra support that people need when they're very sick. It's important to say that palliative care can start at any age and any stage of a serious illness. And heads up, it can run alongside curative treatments. So for instance, if someone is getting treatment for cancer, but they're having a lot of pain or they're having other physical or emotional or spiritual issues, they would be appropriate for palliative care. So palliative care is can happen while people are still getting curative treatment. And it is based on need, not on the prognosis. So it is really important to understand what is it that the patient needs. Okay, we are not going to show you a video because it didn't work, but hopefully later we'll show it to you. But I did want to talk a little bit more about what the benefits of palliative care are. So one of the things that we have a palliative care awareness team, and we've been working on how can we explain well what palliative care is to ordinary people. And these are some of the things that we think seem to work well. Like if you were explaining to someone, whether they live in your home or it's your friend or somebody in your family, why is palliative care going to be helpful? So I think there's really important things that come up. Extra support in your home from a caring team. So you can stay home and there's a team that will come and add extra support. So hopefully that means people can stay comfortably at home with their family or wherever they live and less visits to the hospital. One of the really important parts about palliative care, which is point number 2, is that there's support for the family, for caregivers, for loved ones. It's not just the patient, it's the whole team of people that are taking care of them. Number 3 is really important in that there's a 24/7 someone on the phone to talk to in case there's a problem. And I think that is often, for any of us that have cared for loved ones, usually things happen at 2 o'clock in the morning and you don't know who to call. So that's one of the really important benefits of palliative care. And then there's support for managing problems that people may have, such as pain, trouble breathing, having an upset stomach, but also emotional issues or dealing with paperwork or spiritual issues. Why has God abandoned me? Why is this happening now? The team can come and help with those issues. Number 5, one of the things palliative care does really well is help to talk through treatment options, explaining to people what's being said. I know that this comes up all the time. My doctor said something, I didn't understand it. So palliative care is really good at helping to explain about those things and helping sometimes to facilitate communication with your doctor so they would know what matters to you. And then finally, with palliative care, there are links. They can figure out other resources and programs to help. Is it Meals on Wheels? Is there somebody else that can come with another issue for the family? There's a lot of different resources that are out there that hopefully palliative care can help you link to. So one of the things I was asked to talk about today is an exciting new palliative care benefit. So this is, we think will really be a game changer here in Hawaii. And it is the first time in the United States, we are the first state that has a palliative care benefit that is for MedQuest members that has been accepted by CMS. So that means that we are the first ones, but this is now going to be available to all MedQuest members. And this is a really robust benefit, and I think it will really help because the definition of who qualifies for palliative care means that they can get it much earlier in the disease. People don't have to be very, very sick. They can get it much earlier. And I'll go into that in a couple of minutes. So this is seen as a preventative benefit. And I think I'm a public health person, so I love it that we can be saying we're preventing burnout, we're preventing stress, we're preventing hospitalizations, we're preventing caregiver burnout, that we can really be trying to come in earlier to help. And this new benefit is going to be additional services on top of what's already provided. So what's already provided, not by this benefit, but by existing age, is the medical supplies, the DME, other kinds of supplies, prescriptions, and then other home and community-based services. So I don't want you to think that palliative care will now do everything. Think of palliative care as additional services once somebody has a serious illness. So the question is who qualifies? Any MedQuest members. They can also be Medicaid, Medicare, Medi members. They will have one of these disease qualifying conditions and one functional decline. So there are 17 different diseases that are listed in the memo. I just put some of them here, some of the main things that, that people get: cancer, heart disease, lung disease, things like that. Also, I think it's interesting, long COVID is in there. Alzheimer's, Parkinson's, genetic disorders. So there's 17 different diseases that are listed. So that's step number one. And the person also has to have at least one example of functional decline. So I've listed some of the key ones here. Something, for instance, like durable medical equipment dependency or utilization. So if somebody's on 24-hour oxygen, they're wheelchair dependent, that would qualify them. There's other clinical markers here. I think the last one is one of them that I find might be the easiest for people to recognize. Hospitalization, one or more hospitalizations in the last 12 months, 2 or more ER visits in 6 months, and 1 or more SNF stays in the past 12 months. So you have to have both the disease and the example of a functional decline to qualify. So where can people get services? Basically anywhere besides the hospital. Any place that people live, that qualifies. And then there's other places as well, as clinics and community health centers and other places, including, yes, foster and care homes. So who is on the palliative care team? This new MedQuest palliative care benefit: doctor, nurse, social worker, and what's called a grief counselor. In other types of palliative care, it's usually a chaplain or somebody that can provide grief, bereavement, spiritual support, but in this one, it's called a grief counselor. If it's a pediatric case, then there's a child life specialist, and then there's other people that could be pulled in who are optional, including community health workers, CNAs, APRNs. So how is this going to help you? Well, these folks can help to have eyes and ears in the home, in between doctor visits. It can be an extension to the team that's already there that is taking care of people. Again, this is extra. Nothing is being given up. This is extra. Can also help to advocate for the patient, help communication between different providers, help explains what's going on. And I mentioned before the 24/7 telephone support. I think that can often be very, really important. So there's minimum services that are provided. So there's quarterly clinician in-person visits, so 4 times a year. There's an interdisciplinary team that comes every month. And then there's meetings that happen every 2 weeks that are bi-weekly. And again, as I mentioned, one of the services that is mandatory is this 24/7 access to care. So we really hope that people will be thinking now about palliative care differently and thinking, okay, at any stage in a serious illness, we're here to help. This can help prevent crisis. It can prevent suffering, family stress and burnout, unwanted hospitalizations, emergency room visits, all those things that you try to avoid. that's something that can help with. Advice, support for caregivers. At the end of the day, we really hope that you can hear you don't give up anything, but this is going to be extra support. Okay, so if you are interested in finding out if your residents qualify, or let's just say it, somebody in your family, somebody from your church, somebody that you care about, how do we find out if somebody qualifies for this benefit? Well, you can either contact the patient's health plan, or if you can contact somebody who's already providing palliative care. So at the moment in Hawaii, all of the agencies that provide hospice care also provide palliative care. So hopefully you understand that palliative care is different than hospice care, because hospice care is really that gold standard, excellent care at the very end of life, whereas palliative care can be much earlier in the disease so that people are not ready for hospice. Rather, they are trying curative treatments, but they need that extra support. So I would encourage you, if you already work with somebody, to contact them, because they are the experts at this. I learned so much from my colleagues who are actually on the ground providing the services of what's available, how do they figure out what insurance people have, what they can get. So I'm really encouraging people to do that. And if people want to understand more about the memo and information, on the Kukuamau website, we put up a page all about this new palliative care services benefit. So that's something that you can access. So hopefully you're thinking, oh, I want to know more about this benefit. How do I learn more? We Kukuamau, in partnership with MedQuest, are going to put on a webinar series in March to cover the basics of the benefit, who is the team that'll be involved. We're also going to have a third session on pediatric palliative care. And then we're going to put on one for the public that's going to hopefully explain about the benefit. So we are going to put that out through the Kukuamau newsletter. And I would like to understand from you, and we can do that when the session is done here in the conversation, what's the best way to get you information about these webinars? They'll be free. They're going to be on Thursdays in March at 12 noon. So later on, you can help me understand what the best way is to reach you. So if you would like to understand more about palliative care, maybe watch some videos, read some more information, I would love it if you would go to the Kukuamau website. We've put a lot of information together. And if you see on the right side under quick links, there's two links for palliative care. One is palliative care for patients and loved ones, and the one under it is palliative care for professionals. They both have all sorts of information, as I mentioned, videos and quizzes and all types of different things to try to help you understand more about what palliative care is. So we have, as I mentioned, things for professionals and things for the public, and you can find all of that on our website. So kukuamau.org is the best place for that. And then on that website, you'll see there's these purple buttons. And if you push on those, then you can, you'll find all the things that I told you about. The videos, there's some local videos, and then the where to find palliative care in Hawaii is very important, because that helps to sort out, regardless of where people are in the islands and what type of insurance they have, like what is available for them. So I wanted to next ask my colleague Leslie Milligan to share a case study. I'm going to stop sharing right now so I can see people again. So Leslie's going to do just a short case study to tell a story, which is always a good way to share.
Can you hear me okay?
Yes.
All
Go
right.
ahead, Leslie. Thank you so much.
No, aloha everyone. Thank you for allowing me to speak to you guys to share this case study of a patient who was receiving our palliative care. And she was originally, so of course we're not using names. I'm just going to share that she's an 80-year-old female who originally started palliative care in the home. She was staying with her son, but eventually transferred to a foster home setting. So I thought it would be a really good one to share. So let's start with 80-year-old female diagnosed with advanced non-small cell lung cancer. She was a former smoker. She quit about 26 years previously. But when she was smoking 1.5 packs a day. She was experiencing a lot of pain and symptoms, had moved from New York to Hawaii several years prior. And this is where she raised her one and only son, who ended up being her caregiver. But he also worked a lot. And she had a lot of support from her daughter-in-law, who worked from home, but also was working a lot. And they had two teenage sons. She was very close to her family, had a sister still in the East Coast who actually was a retired nurse, and actually had her niece who was an ER physician back on the East Coast. So very, knowledgeable support group, very opinionated support group, but of course, because they're advocating for the patient. And we worked, alongside the family to just help navigate her through her treatment. So as Jeanette mentioned, and I think you'll hear that as I'm going through this case studies, a lot of the ways that Jeanette described palliative care, you'll see it in action through this case study. So she had non-small cell lung cancer. She was actively seeking treatment. Despite the treatment, both chemo and immunotherapy, her disease continued to progress, but we wanted to make sure that her journey was as comfortable as some of you have mentioned, and supported as much as possible. So what we did was we had our palliative care program. We were sending in a nurse practitioner once a week to help support her. She had a lot of pain and symptoms such as her pain, and then she had her nausea, shortness of breath, she had lack of appetite. She was frequently being hospitalized due to these things, as well as pulmonary embolisms, pneumonia. And so a nurse practitioner was seeing her once a week and helping manage these pain and symptoms, was an extension to the already in place care team. So served as Jeanette had mentioned, the eyes and ears for the doctors in between doctors' visits and treatments. The doctors really appreciate when we're involved, because what we have seen is that what presents at home or in the foster home is very different from what presents in the office. And that's very helpful for the doctors as well. And throughout her time with us, she had used our 24/7 support nurse triage line often. And we were able to prevent some unnecessary hospitalizations. For example, unmanaged pain, which she would in the past would have only had the option of going to the hospital. She could call our nurse triage line. And although on our palliative program, we don't provide an in-person visit, we were able to get in touch with our nurse practitioner, who was very familiar, obviously, with the patient, was able to prescribe the necessary medications that she needed. So we had a lot of instances like that where we're able to help with her appetite by prescribing her appetite stimulants, help with her nausea by prescribing the necessary medications. So clinically, very much there to support not just the patient, but the family as well, especially when they were starting the caregiving in the home. Eventually, it became a little bit too much for the family to manage, and so then transitioned to the foster home. I look like I'm running kind of short on time, so I wanted to just explain also that besides the clinical support, we provided social work support. This social worker actually helped to find foster home options for the patient, as well as help navigate and start the long-term care conversion process with the insurance company, so that it was a very fluid transition to a foster home. We helped with advanced healthcare directive planning, filling out the post, starting the POA process. And then we also provided spiritual care support. So this woman was very strong in her Christian faith. and we were able to, and she was very involved with her church, but now she was unable to go to church services. So we were able to send in our spiritual care provider to have one-on-one sessions with her and really make sure that her spiritual needs were being met. And our team was there not just for her, but her family as well. And also for that foster home operator, because we continue to advocate for the patient and serve as that, extension to the already in place care team. So we help navigate through follow-up appointments and helped, discern through medical documents. And so at the end of the day, I just wanted to say that everybody was winning, right? The foster home operator, the family, and the patient. She was on service with us for over a year.
Great. Well, thank you, Leslie. And we can talk more, as I understand it, once I'll finish up my last couple slides, and then we'll have a chance to talk more. So again, thank you, Leslie. So, you heard from me, and now you also heard from Leslie. Like, these are some of the important things that we hope will resonate in Hawaii. Especially things like support for the family, support for, we know there's a lot of burnout. We know, I can't even imagine how hard it is to run a care home like you do. Hopefully this can be extra support for the loved ones. We, that palliative care is appropriate for elderly people. It's not only for the elderly, but it certainly is the, we know that most people who with serious illness are older, so it definitely helps as we care for our elderly folks. And again, you don't give up anything, and you can still be getting something curative at the same time. So just to finish up, this is my colleague, Dr. Daniel Fishberg. He really likes this image. So in the first one, the people are having a palliative care consult. It's pouring with rain, and then the doctor runs after them and hands them an umbrella and says, "Here, this will help." And she says, "Thanks. I wish we'd had this earlier." And then in the early palliative care referral, the doctor hands them an umbrella. "You may not need it yet, but just in case." And then a few months later, when it's raining, she says, "So glad we had this when we needed it." So you can plan ahead and have that extra support. So remember, palliative care is the umbrella, not the rain. Predicting the rain can be difficult, and having an umbrella will not bring on the rain. Wanted to finish up with this quote that I really liked. "I felt like I was drowning. So many doctors, so many medical terms I didn't understand. My palliative care team took the time to help me understand and find a way forward that works for me." So this is my contact information. Hope Young is the other Kukuamau person. People may know her because she does talks on advanced care planning as well. And we're happy to help in any way we can. So I'll stop sharing my slides. I did want to say people were asking how they could sign up for the webinar. So I'm wondering if you guys have a group and I send it and you can help me send it out. If you want to send something to info@kukuamau.org, like Renata asked, then I can forward on the announcement that we're just finalizing. So the webinar is just about done, and so it will be very relevant with information. So I'm interested in the best way to do that. So I will stop now and turn it back over to you, who's ever in charge.
Hi, Jeanette. Can I go ahead and just interject? So your question is how you can disseminate the information, the best way to do it. For care homes, the best way to do it is to send it to Justin at Department of Health, and he'll go ahead and disseminate it to all the licensed care homes through him directly. And whenever he sends anything out, it does get everybody's attention. So that's the best way for us.
Okay, that's it. Justin, you'll be hearing from me.
Hi, Jeanette. There was a question in the chat regarding a diagnosis to qualify for palliative care that Renata submitted. She asked, what if it happens that the cancer is classified as being in remission? Would they still qualify for the palliative care program?
Huh. What do you think, Dr. Fernandez?
Yeah, I think, because if something is in remission, that doesn't mean you don't know whether you have 100% cure. And you could look at other things like ER visits, hospital in the last 12 months. Because most people don't have one single disease. They have so many comorbidities and so many past medical illnesses. So another question that came up to me is, what about they had candidates who graduated from hospice? Can they consider palliative care this new benefit for those?
Absolutely.
Yeah, thank you.
Yes. And I think one of the important things about palliative care, it's really much closer to the definition of palliative care. So someone has serious illness and then need extra support. That's where palliative care can really help. Yes, and that's one of the problems, as we know, they graduate from hospice, they've gotten really good care, and then we wait until they get sicker again and qualify for hospice. That's a really bad plan, right? We want to be able to support people well, and hopefully they can be using that palliative care and not need hospice, but can get better. So that is certainly, that's the goal. And I think all of us can think of cases where with that extra help, extra support, they could have avoided, a downward slide towards something so that they could be and having, again, extra eyes, having people ask something. I think that all of that will really be helpful with this new benefit. So I think it could really be a game changer. So let's be serious. It started on January 1st. So we are all moving to get this up, which is why the webinars are still under construction. So you didn't miss it. It's now under construction. So my colleagues at for instance, at Aloha Care are very involved with figuring out who qualifies and all of that. And so there's a lot of good work going on, but we hope that relatively soon, patients will be able to, take advantage of this. I'm not going to give you any dates, but, pretty soon. People are really trying to push this forward quickly.
And for the palliative screening tool, are they the only ones that are able to do that? So it could just be a doctor's appointment for that appointment, to get that screening completed?
Good question. One of the interesting things about this benefit, and again, I do not claim to be an expert on the benefit. That was a 47-page memo, and I didn't memorize all of it. But one of the pieces I think is really interesting about this new benefit is that there is an assessment that people can bill for. So if someone's able to bill for services, a physician, an APRN, a social worker, they can do an assessment. So it could be done in a physician's office, but it could also be done by another health professional. And I think that's actually going to be a really interesting addition because they will be paid for it. And they'll be able to then give a heads up to people about, if they would qualify for palliative care. And one of the things that we see a lot of in palliative care is very cute, is that oftentimes people wait and wait and wait, and they're actually appropriate for hospice. So hopefully this assessment, we can get people earlier so that we can be getting them that palliative care support. But then if there's an assessment where they are appropriate for hospice, then that can happen as well. Does that answer your question?
Yeah, yes, definitely.
I was also, if I can interject, that we can also get a referral for our palliative programs from the community. So it doesn't always have to come from a provider. I mean, obviously it's easier if it comes from a provider, but we get a lot of community referrals and then we just follow up and get authorization for release of medical records and then pull the necessary records to assess if patient would qualify.
Yeah, I know.
So Adela,
Hi,
I'm sorry, but your computer, you're not muted. Okay, was there another question?
It's Naomi. I wanted to say something.
Yes.
Hi, folks. This is Dr. Marita. So, hospice and palliative medicine and palliative medicine physician. So, interesting question about who may refer to palliative care. So, one of the things is that Jeanette and Kokuma have done a fantastic job of building a whole supply or cache of information that you can always refer to. And she has created one of those lists about in terms of the screening criteria or ticklers to be aware of in terms of like say you have a patient and they have a symptom that's on that list, yeah, Jeanette, then you as yourselves as care home operators or nurses or even any lay person can say, oh, aha, because I've been teaching this to everybody, this list that Jeanette's provided, and so that people can be on the alert, right? Anybody on the team, any lay person can also say, hey, this person has this criteria, even one of them. And so let me tell somebody on the patient's medical team or tell somebody on the family, hey, well, how about checking, I think your blah, blah, blah may qualify for palliative care. And so maybe notify the doctor, notify the nurse, notify somebody on the care team and so you can be the first alerts to helping these patients start the trajectory of getting the care that they need and deserve.
Yes, absolutely. And I think that as you learn more about the benefit, you saw that there were 17 diseases and then the functional decline list. It's straightforward. You don't need you don't need to be a physician to understand whether somebody's wheelchair bound or had several visits to the emergency room or so you absolutely. And that's one of the great things that you as care home operators can really be on the front lines. So Angel mentioned that there's usually cancer, congestive heart failure, and COPD are appropriate for palliative care. And traditionally with HMSA's supportive care, that was the case. But now this new benefit will have 17 different diseases, including dementia. I mean, we had that whole list. So it's yes, these three plus the rest. So that's why it's such a big difference. And to let you folks know, supportive care for Medicaid members will be ending at the end of June. So this new benefit will take the place of supportive care from HMSA. So there will be discussion about what that means, but this will be now for so that program will stop. But the thing, if you know about supportive care, it's for 3 months and people have to really be quite sick, as opposed to this new benefit. People need a serious illness, but it doesn't need to be, for instance, advanced cancer or advanced COPD. So hopefully, again, we can be getting people much, much earlier.
Yeah, and in addition to what Jeanette mentioned about this MedQuest thing, you guys hear a lot about supportive care, but it's also really important to know that there are other health plans that have their own palliative care benefits, and they all vary in terms of criteria. But for me, I'm just so you know, like UHA, well, usually for younger patients who are employed, but there's no limits. I mean, there's no time limit, any diagnosis. So UHA is very easy to utilize. The VA used to be like that, and then for a while they had limited criteria, limited diagnosis. But I believe, and I'm not sure at this time, but they've opened up the diagnosis to be broader, more like UHA as well, and no time limit. Only thing is they have a new limitation with the VA is that interestingly they have a limit of they say that if the prognosis is 6 months or less, which sounds very similar to hospice. So that's something that's I find puzzling. But and then Jeanette could probably give you more details about all the other different plans as well. But
Right.
it's very confusing. And Jeanette, I mean, you did a fantastic job of explaining this MedQuest benefit. I learned a lot myself today. Thank you.
So I was asked to only talk about the MedQuest benefit, which is actually much easier because, as Dr. Marita said, there's different names for different programs and all of that. So today we're just talking about the MedQuest palliative care benefit. It's being called palliative care. And if you have a family member with a different type of health insurance, you can go on our website and look and see, or as Leslie has said too, you can contact one of the palliative care agencies and they can help you sort it out. And if you know if you already have a relationship with one of them, I would always recommend that because they're experts like Leslie in sorting all this out. So thank you very much. Yep. So I'm just checking if there were any questions.
Yeah, I have a comment regarding palliative care. Back in 2023, I want to say there was a short stint where the state had the palliative care program. I'm from Kauai. I had a member who was on a palliative care program, and the benefit was extremely important for the family who were had big jobs, they were out for hours at a time, and having that extra support from the hospice agency, but it was palliative care. It was amazing. And it was maybe about 1 or 2 months, but they were able to get the DMEs quicker than I could, when I came on board, as I'm a health coordinator. So that palliative care program was so instrumental in getting my member to a place where when that program was gone, we already knew kind of the steps we needed to take in order to keep him healthy and keep him alive as long as we did. So I'm very happy that this program is coming out. I've been asking our one of our managers here, when is the palliative care coming back? Because for Kauai, we do have a lot of members who would benefit from it. And I really hope that it does create better lifestyles for people who do have these, comorbidities, that this could really help them.
Yeah, thank you. I know that people were disappointed when that started and stopped, but now we're here and it's moving forward. And if you can help spread the word about the webinars and spread the word about this palliative care benefit, especially on your community on Kauai, I think that would be great. And there's lots of opportunities of how to now get this new benefit for people. So thank you for that.
Oh, Jeanette, may I say something else again?
I'm not running this session. Dr. Rita Bell and Juanette are, so I don't know.
Okay,
Yeah,
I'm just going to say, so yeah, thanks, Rita Bell. So the other thing too is one of the things that's really confusing for many people is that currently, the different organizations haven't had time to build outpatient palliative care or clinic palliative care consult services. But in the interim, there has been palliative care benefits available through the different insurance companies, as you may be aware. And what's really confusing is that the palliative care teams, the current palliative care teams and agencies are housed within hospices. So then people think, okay, I got referred to palliative care, but why is St. Francis Hospice calling me? So it's very confusing, right? So just to know, right now, all the palliative care teams or agencies are housed within hospices. And so don't be too shocked if the hospice calls your care home and says, I'm going to be doing a palliative consult on your client because it's the palliative care people, or they could be one and the same. So when I was a St. Francis Hospice medical director, I mean, I did hospice and I did palliative care, and the nurses did the same thing based on region. So the nurses could be doing, being on it was the same team providing palliative care or hospice care. So just FYI, another point of confusion for a lot of folks. But so yeah, Jeanette, I guess Jeanette, we know that there's these different private organizations are probably really anxious about building their own healthcare agencies now. So we'll see what happens, well, when they'll be ready, because they're not ready right yet. So maybe later in the year they might be ready because they have to build these teams and find the experts, which are hard to find. So
Right.
I think,
and I believe on this island, all of the agencies that currently provide palliative care are going to also be trying to, sign up for this new MedQuest palliative care benefit. But yes, there will be other people that come in. And thank you for that. I think one of the hard things in Hawaii is that at the moment, palliative care is a service that's also provided that the agencies that provide hospice also provide. So that's why I think it's also very important to understand, and especially with this new benefit, we are talking about really much farther upstream. And I think Grace, I'm a Grace too. Great name. Thank you, Grace. Important to say, hospice, this new palliative care benefit, it is not the same as the hospice qualifications. These are people who do not qualify for hospice. They are much earlier in the disease process. So these are not the same as hospice patients. And then if somebody then does progress and they get worse, then they would qualify for hospice. Then they would no longer be on palliative care. And then the hospice benefit that we know, that is all of the services and the wraparound services and support that hospice provides, they would come in, and then the palliative care would stop. So just to be clear about that.
Well, I think we have to add this caveat that a lot of folks, a lot of patients, and their families are so frightened by the word hospice
Yep.
that if they're able to, I kept my patients on palliative care services, even if they qualify. Many of them who come to palliative care actually qualify for hospice, but they're too afraid of the word. So we give them the palliative care title, but they're still receiving the same services.
So I think it's important to say that this new benefit is going to be is different than supportive care. So supportive care was a wraparound service. That was a full-on benefit. And this one is different, so that if people, I think it will be a really interesting learning for all of us to figure out these transitions to hospice, helping people to understand all of this is now is a lot about helping people to understand that they'll be getting good care. And then they're going to be getting it through hospice. So I think that this will continue to be an issue of having people afraid to talk about hospice, but that's why we need all of you. So Leslie, you said you had some comments.
I just wanted to thank Dr. Marita for bringing that up, because it is something that we had experience, as we meet with the community, when we meet with patients and their families to discuss our palliative care program. And also just that word palliative oftentimes is seen as synonymous, the same thing as hospice, which Jeanette and we're all in a palliative action committee to work on that, tools for which you can find on Kokomo, by the way, on the website, on, the different, how should we say, Jeanette, the different language we can use to clarify what palliative care is, and that it is not the same as hospice. Because we are trying to identify people more upstream, I've been trying to educate our providers as well that if somebody doesn't quite qualify for supportive care yet, because maybe they're stage 2, at least for our palliative program right now, we can still accept them onto our palliative care and then transition them to supportive care should they meet the supportive care criteria. Same thing with the other programs like VA concurrent care or UHA concurrent care.
Right. And so I think, again, this will be interesting to see what this means for this new MedQuest benefit. So do you see new outpatient palliative care providers entering the healthcare system? I think that quite a number of entities are interested in how they can make this work. And I think those are people, for instance, like long-term care facilities who have people living in one place. They already have beds, they have staff, they now have an opportunity to bring in extra support where somebody lives. And I think there will be other groups that are looking at this. So again, it's brand new. We are trying to understand it. And I think that, understanding the benefit is important, but I really appreciate here the conversation about how we talk about this. And we have things on our website we can, I think practicing how you bring something up, figuring out why people are hesitant to talk about certain things. And I appreciate that hospice can be very scary. We all want our loved ones to be with us forever. And hospice is, I know, makes a lot of people very scared. On the other hand, we need to have people figure out how can we help them understand that this is really the best care possible. And this is the care that is going to help them, help their family. But yes, it is really a lot of the agencies like Navient used to be called Hospice Hawaii, and they've now changed their name to Navient. Bristol calls themselves Bristol. Other people like on the Big Island, Hospice of Hilo has changed their name years ago to Hawaii Care Choices because they were trying to help people be less afraid. St. Francis usually calls himself St. Francis. So, but we need to figure out how we can also have people not be afraid of hospice. So, did I miss anything in the chat? Sorry, I wasn't paying so much attention. Oh, the Foley catheter. Thank you, Dr. Morita. I don't know, Melissa, if other entities are going to put together palliative care teams. I think it will be interesting to see what people come up with. Kaiser's a really interesting, they got a lot of people. They do good palliative care inpatients. They're working on the outpatient. So, but hopefully, so as we finish up, I see in the chat already there's the evaluation, so I know that you're going to be asked to do that. But if you have any questions, feel free to contact me. I'll send out the announcement to Justin at the Department of Health about these upcoming webinars. And again, this is we're less than 2 months since it began, so everybody is still sorting it. I see how care homes can really be a part of this and also benefit from this new palliative care option. So I'll stop talking now, Juanette.
Thank you, Jeanette, for that very informative presentation. And for all the attendees here or caregivers for foster homes or care homes, when you go to do your evaluation, and the link is in the chat, you'll come across this screen. And if you could please go through it carefully. So as you can see on the screen, it will ask you the total number of residents that you have or patients that you have in your home, whether it be foster home or care home. It says resident 1. If you could please start with the resident that you admitted first. So the ones that you've had the longest in your home. So let's say you admitted a patient, your first patient you admitted 3 years ago, you would check that box 1 to 3 years. And that would be your resident 1. And you go through all the 3 questions. Please answer whether yes or no. And if you have more than 1 resident or patient, click the plus sign, and then you're going to enter your resident 2, which is the second, oldest, I guess. It's the second resident that you admitted into your home. Again, start from the oldest to the youngest or to the soonest admission. So is that clear? Let me know if it's not clear and come off mute. And if you have 3 residents, just keep going until you have entered all of the information of all the residents that you have in your home. Thank you so much. Feel free to email if you have additional questions. And again, in order for you to receive certificate of attendance or CME or CUs for the licensed folks that are on this training, please complete the evaluation. So 1 per person. If you attended as a group, you have to individually do the evaluation. Thank you so much for being here. Have a great afternoon, everyone.
Bye, everyone. Thank you.
Thank you.